Hello, guys. Thank you for being here. My name is Janaína Koenen. I'm an endocrinologist. I live in Brazil, and I work with lots of metabolic diseases like diabetes, obesity, and also I love studying about cancer. And in my life story about cancer, which I'll tell you eventually, I came across this person's book and this story of life, this example of life. And this is Jane McLelland's story. So, Jane, thank you so much for being here. I'm so happy. Like,
Well, so am I. It's one of my doctor heroes, you know. I love the fact that you do what you do and you're working against the grain, you're not supported in what you do, but you know it works. So I'm delighted to be talking to you.
You know, the first time I heard about you, I was in Metabolic Health Summit, and I was
Yeah.
lost, like looking for answers and no one to talk to. And I came across Nasha Winters, and she said, "Oh,
Yeah.
Janaína, you're a doctor," and she was so excited from Brazil. And wait, have you read Jane's book? You have to start reading Jane's book. You like supplements? No, you have to read Jane's book. And then I said, Jane McLelland's? Okay, I didn't know the book. And I know it's How
No.
to Starve Your Cancer. I said, okay, I'm going to buy it now. I remember buying it in Amazon, like at the spot, you know. I said, this is the first thing I'm going to do. I'm going to eat this book from the beginning to
The
end.
Metabolic Health Summit, the Metabolic Health Summit, they have a lot of books on display. They have never sold my book there.
But that's disgusting, you know.
I've asked them, and I don't know why. But anyway, hopefully next time.
I'm going to
they
do
will
this.
have it.
I'm going to talk to them.
Yeah.
You must sell your book there. You know, I'm going to do it. Let's try. We'll do it.
Okay.
Because it's worth
Thank
it.
you.
You know, your book changed my life, changed my practice. And you'll see what I'm going to do with I used the information in the book to begin a work. I told you about it a while ago. And it's almost ready. And I put another stuff together, and I did a systemic thinking of mine. You know, every time you do something new, you put some of yourself in it. So I did that.
Yeah.
And as soon as it's ready, I'm going to show it to you. I think you're going to love it because you inspired me so much. You know, you are like
but you're so clever, and you take what you learn, and you already know so much, and you've just applied. I can see what you've done. You've applied my thoughts, and you are actively using it in a way that I feel doctors should. So
thank you.
Well done.
So let's people get to know you. So tell us your story. Where are you from?
Okay.
What happened to you? What changed your life? And why you are now an icon, you know, in cancer treatment, and you inspire so many people today.
All right. Well, I was born on a little island called Guernsey, which is close to France, but it's part of the UK. Well, it's not part, it's part of Britain. Anyway, I was diagnosed with cervical cancer at the age of 30.
Cervical cancer?
Yes. So had hysterectomy, so, you know, the chemo, radiotherapy, the normal treatments that you have. That's all I did at the time. I didn't think about doing any holistic treatments. I didn't think about doing anything else. I just assumed they would cure me.
How old were you then? 20?
30. I was 30.
Yes, 30.
So yes. And it had already spread to my lymph nodes, quite a lot of them at that point. But I didn't really recognize just what an issue that might be, and that the chance of spread was that much greater. Anyway, my mother, between me having my primary and my secondary, my mother actually got stage 4 cancer. And she opened up my eyes to the fact that I really was in a dangerous situation. But I tried to get some treatments for her, but we really didn't have enough time to make anything work. She was really quite advanced at this point, and she wouldn't listen to anything about changing diet or anything like that. She just listened to her doctors. So I failed with her.
And, you didn't fail. Don't feel like that. You didn't fail. You know why you can't say that? Because people at home never listen to us like they listen to people outside. You know, my father died of cancer. Mm-hmm. My aunt had lung cancer, smoker. My mom still smokes. So don't worry about that. It's not your fault. You tried. You didn't fail. You didn't fail. If you tried, you did your best,
yes,
I'm sure.
I did my best. Didn't get anywhere. And then I realized I had to do an awful lot of changes to my lifestyle, to the way I was eating, to sleeping, relaxation. I needed to look at my stress levels a lot more. There was an awful lot that I had to change. So I then incorporated all sorts of things into my I cut out lots of things in my diet, like meat, dairy, obviously all the high glycemic stuff and bread and wheat, things like that. So that all came out of my diet. I then did an awful lot of supplements. I had ultraviolet blood irradiation, intravenous vitamin C.
But how did it start? Like, how did you start taking supplements? Where did you look for it? Because you did a massive research.
No, I didn't. It was very hard because this was back in 1999 when I was diagnosed with a secondary. The first one was in 94. So it was mostly through trawling through. I had Life Extension magazine. I had the Townsend letter. You're probably familiar with both of those. I had various journals that I was looking through, alternative medicine journals, all sorts of things, just trying to crib as much information as I could.
You didn't have PubMed, you didn't have Google yet, right? So it was such a hard work.
It was really hard work. And then I was quizzing so I had more than one integrative doctor. I thought I will go and see as many as I possibly can, because I thought education here is king. It is what you need. Power is having control over the knowledge of what you need to do. And I felt totally disempowered by everything that was happening to me, and I felt I needed to get back that feeling of control. So it was education was my big, and it still is the big thing. And I still try and, this is what I do now, is I try and teach other people what they need to do. And it's terribly empowering. So I managed to keep my stage 4 cancer under control for quite some time, quite a few years. But then my blood markers started to go a bit wobbly.
Which blood marker did you use?
PKM2, which is
usually doctors don't ask for it. That's why I'm asking. So
no, it's an unusual marker, and my MMP2, and I was looking at my natural killer cells and everything else, and they were really suppressed. And my MMP2 was too high. My interleukin 15 was too high. There were also 5. Sorry, interleukin 5 was too high. So I was out of kilter with a lot of things. But my PKM2 is a marker of glycolysis, which is the fermentation that cancer goes through. And this is an enzyme that goes up when you have cancer. And this was going up. And I also had myelodysplasia in my blood. So my bone marrow had been affected by the chemo and the radiotherapy I'd had previously. So I didn't want any more chemo. So I looked at trying to do something different. And that's when I started to look into, because the supplements weren't controlling it. That was the problem. Whatever I was doing, it wasn't enough. So I knew I had to look at something else, which was more powerful. And that's when I started to add these what's known as off-label drugs. So these are drugs that are used for other conditions that I then use to help supplement into my cocktail in order to make it effectively starve the cancer more efficiently, because it was blocking various pathways that the cancer used to feed itself. So like glycolysis, I was taking melatonin, I was taking vitamin C, intermittent fasting, I was kind of pulsing into ketosis a little bit, so really lowering my GI index to try and starve the cancer. I was blocking glucose receptors with things like quercetin. I was taking berberine. Berberine is now commonly used as a supplement by cancer patients, but back then you couldn't even get it as a supplement. I'd come across some information in a herbal magazine that was talking about berberine as part of Mahonia aquifolium, which is it's a herb that the Chinese have used for a long time, and it had the berberine, oxyacanthin, all of these things. The ingredients were really powerful for cancer, so I had to take that as a tincture because I couldn't get it as a supplement, but now you can buy it easily as a supplement.
Here I can manipulate it in a compound pharmacy. I can manipulate everything I want. So
great. So that was kind of the nuts and bolts of what I did. But so I then added these drugs, and one of them was lovastatin, which is one of the original statins. Hardly get that very easily anymore these days. And then I added dipridamole, and that's an antiplatelet drug. It doesn't decrease your platelet. It stops your platelets sticking together, but it also blocks one of the cholesterol pathways as well. So I was blocking 2 cholesterol pathways. And then I was taking the berberine. I was taking Itodolac, which is a non-steroidal anti-inflammatory.
It's an excellent combination.
Yeah. So that was part of my combination. And what else was I taking? I later took cimetidine.
You took metformin too, right?
Yes, I didn't take it initially. I took it later on. So the berberine was kind of my equivalent of the metformin to start with. But about 2007, I started adding the metformin into my cocktail as well. So yeah, that was also that became a standard part of my protocol going forward. But I'd already got it under control at that point.
And it disappeared. What happened afterwards? So tell me.
So initially, I took it thinking, well, I don't think this is going to work. It's not, but I might buy me a few months, and that's all I was hoping for. And then 7 months later, my PKM2 it wasn't quite in the normal range, but it was pretty near enough, and blood markers all looked fine.
Did you do any image by then? Like PET scans,
no.
CT scans?
No, didn't do any of that, actually, which is a shame. I wish I had done some more of those, the evidence around that time. But anyway, it then started, the markers all started. So I dropped all the drugs because I thought I'm fine. And this is something I see a lot of cancer patients doing is they get better. Oh, I'm clear now. And then they drop things too early. And I see it again and again where people, they think they're okay, and then cancer comes back. And it happened with me. So next year, again, markers start shooting up. So take all my cocktail again, but this time I stay on them. And in fact, I've come off them occasionally, but mostly I still take dipyridamole at night. And in fact, take a statin at night. I've got the 2 dodgy APOE4 genes, 2 of them, like Owen Hemsworth. So I know that I'm sort of at risk for Alzheimer's and things like that as well. And I know that it's linked to cholesterol problems and things like that. So I know taking those 2 for me is probably quite important ongoing.
Actually, the statin could push you to Alzheimer's disease,
Starting to push you towards
Alzheimer's disease. Statins, they raise the risk of dementia. So maybe what can you do to improve that? It's I don't know. Do you take sulforaphane?
Yes.
Because
for dementia, yes, statins can cause a temporary increase in dementia. But actually, there's studies to show that in fact statins for Alzheimer's, which is different to dementia, it's helpful.
Yeah, let's talk about it. Let's exchange articles and papers. It's good. I read a lot about it. I love it. So I'll be glad to change to study together about it. Yeah. But then, how many supplements do you take in total, like nowadays? Numbers, like how many supplements? Yeah, now.
Okay, I don't take that many. I'm pretty slack these days.
Okay, but until when did you take all of them? After this recurrence that you said, when you were like, okay, I'm okay, then you started again?
I carried on taking a big cocktail for about another 2 or 3 years. I've gradually tailed it off.
How many supplements were you taking?
Oh my God, a lot. So, and I'd take some of them 3 times a day.
Yes, I know, but like categories, like berberine. How many?
Yes, so I took between 20 and 30, but sometimes 3 times a day. And then I take a different cocktail at night.
Okay.
So
it's like 25 different supplements.
Yes.
It's like 40 pills a day. Sometimes. A bit more. Okay. Yeah, I mean, I see sometimes patients telling me, doctor, but listen, I'm taking 10 pills in the morning, 10 pills in lunch. I said, listen, okay, cancer is a metabolic disease. It's impossible to tackle cancer with one drug because it's a metabolic disease which has many pathways. And then I show them your map, I said, look, there's this huge, beautiful drawing, Jane McLelland, and you must read her book. And I tell them to read your book, and I said, you have to understand how cancer works. So I'm teaching my patients, I'm showing them, I'm recording like lectures for free in my YouTube so they can look at it, When they said, ketogenic diet will make you lose lean mass, I'll show them, no, it's not going to happen if you have a nutritionist, if you have calories, if you have protein, enough protein, not too much protein. It actually prevents cachexia and treats cachexia if you have the right supplements. And actually, these supplements we use prevent cachexia too. So it's interesting that when you see that our supplements, what we use today, and the combinations can actually improve your immune response. You said your cytotoxic T cells, they were low. So let's tell people now. Okay, now they are scared because it's a lot of supplements. But people, you have to understand. Look, this woman was supposed to die when she was 35. She had myelodysplasia. How many patients survive after chemo, radiotherapy, myelodysplasia, and don't start another chemo after recurrence, and they survive? If you find someone, tell me. I'd like to interview them too. So it worked, okay? So now we have to find out why. So this is what we are going to start talking about now. Why did it work? Yeah, because I completely agree with Jane McLelland. I agree with the theory. I have seen it in my practice, and I really want her to tell you, because she was the first one. I mean, lots of people talk about nowadays metabolic treatments and stuff like that, but not many people have a systemic view of cancer like she does. It's a systemic view. I read it all, like everywhere. I looked into it because my father had cancer. I had to help him. It was 2017. There was nothing there. I didn't know about Jane, so I was looking in PubMed and trying to find something, and I didn't find anything. So what I found, I used. It worked for a while, but now, seeing what she has accomplished, I think we must listen to what she has to say. Like everyone should, because she's like a compendium of medicine, of metabolic cancer view. Yes, I mean, it may not be perfect, Jane, but
it's not perfect.
Yeah, but you know what? Listen, it's better than what we have. It's better than what we have around. And you are a constant source of ideas, of research ideas. Like the scientific community should be in your course. I took your online course, of course, I did, because I read the book and I was kind of lost. I said, okay, no, this is something really big. I have to do something with this. I had another ideas. Some of them I shared with you about mushrooms and about other stuff, like when we met. I have more ideas now. I have great ideas. I want to sit with you and tell you about it. We can talk today about it, actually. It's okay. And I think it's like a source of research because you give so many ideas, If someone is clever enough to stop, look at and hear to what you're saying and dig into it, they are going to come out with a lot of, research protocols. I mean, everyone should be doing this, But they're not, because they are just focused on continue with their stupid lives, eating sugar, sleeping late, and taking medicines. That's what they like doing. So,
yeah. And it's an easy way out to do that, but unfortunately, it is the way out. It's not the way.
Yeah, it's the way out to the other dimension, right? That's why so many people are dying every day.
Yeah.
So tell us about the pillars of the. Let's talk about energetic pathways first. Then we talk about the other ones. So
all right. So I do have 4 pillars of my approach, and the exercise is key. They're all key. The diet is key. The supplements, because there are specific supplements that really work very, very well, and obviously the off-label drugs. So it's a combination of all those things. One thing on their own is unlikely to create a cancer-free zone. You really have to work on all 4, and I think exercise is the one that probably always comes to the bottom of the pile.
And you're a great sportist. Tell people what to do.
So I sail a lot.
Even when you were sick, you were sailing, taking your pills. I remember in the book you telling this. She went sailing. No one knew she was taking so many pills.
No, I was trying to hide them. Rubbish. I couldn't do that. But anyway, so Yes, do a lot of sailing, do a lot of cycling. I used to play a lot of golf. I don't do so much of that now. Used to do a lot of karate in my time as
Wow.
well. So, but I still do my Peloton regularly. Got a Peloton bike, but I used to go cycling a lot before Peloton was even invented. You know, I'd do quite a lot of cycling. And I would prefer to do more aerobic stuff, but I've got really dodgy knees. But I would say that aerobic exercise plus weightlifting, actually, people don't realize that weightlifting is really, really good. I mean, there's a guy called Dave Bolton who has starved his brain cancer completely cancer-free, and he did it mostly by exercise. And he's got fantastic muscles. He looks amazing. But he worked really hard on trying to starve his cancer that way. Not everybody can get those big muscles, but he did. He's done phenomenally well at using exercise to starve his cancer as his predominant thing. He used diet as well. I suspect he probably used a few supplements and things as well. But the whole point is that it's always a combination of stuff that you need to do. Don't rely on one thing. Too dangerous just to rely, or certainly to rely on your traditional treatment alone is asking for trouble.
Most of the time,
when you've got-
it is.
yeah, you got stage 3 or stage 4 cancer. I would definitely do not rely on traditional treatment to get you better. You're lucky if it works, but you're really taking a bit of a gamble with it. So those are my main 4 pillars. And if you want to talk about the off-label drugs and the supplements, those are the ones that really, well, also the diet and the exercise also attack those metabolic pathways. But I've mapped out these pathways, as you say, in my metro map. So this is like little triangle in my book, which kind of splits the 3 macros of the diet. So you've got carb, fat, and protein on the triangle, and the carb is mostly glucose. The protein are mostly amino acids such as glutamine is the one, and then the fat pathways at the bottom. So lots of those too. And cancer, unfortunately, learns to feed on lots of those things. So it needs, in order to create a new daughter cell, it needs to make protein and fat. So it breaks down lots of protein and fat that comes in and recreates it to create those nucleosides, which are those sort of the little chunks of DNA to make the new nucleus. And then it makes all the organelles and the fatty lipid membrane. So it's constantly trying to do something in order to create its daughter cells. And if you can block its processes of being able to do that, then it starts to wither away because it's so hungry. Most cancer cells have about 10 times more glucose receptors on their surface than normal cells. So if it doesn't get that supply of glucose, it starts to shut down. And that's what we want to do, shut it down. And eventually it starts to wither away and die.
Especially if you do stuff like that. For example, in people undergoing chemotherapy, for example, they could do metronomic chemotherapy and use insulin pre-chemotherapy, and take advantage of those insulin receptors and glucose receptors. And most of the doctors simply ignore this fact. They use high chemotherapy doses, even in those patients who can't tolerate it. They don't even know about insulin, which is something so old, like older than me, and no one talks about it. So they think it's one thing or the other. They don't understand that if you're taking action on the metabolic pathways, energetic pathways of the cells, they are most sensitive to chemotherapy and radiotherapy, right? And some supplements even make the cells more radiosensitive, like doxycycline, for example, like Osvelia, like Verin, you know?
Yeah, amazing. Yeah, really sensitize. There are a lot of things that will actually sensitize the cancer to various treatments, and that's what you need to do. And it's all about educating yourself, looking up your particular type of cancer and trying to work out what is the best sensitizing agent for, say, the chemo that they put you on, or even the immunotherapy, PARP inhibitor, targeted drug, whatever it happens to be. you know, there are ways to make it work better by adding different supplements and different off-label drugs and different diets, etc. That all of that will help it work better.
And what have you seen, for example, in all these years after you began speaking it out and telling people about it? I'm in your Facebook page. There's a Facebook page where doctors and patients change experiences. Sometimes I don't have time to go there often, but always when I go there, I have trouble leaving. And I often find myself at midnight reading and writing things. And I see many people having success stories with these approaches. So I'd like to tell us like one story that touched you in a different way, besides of your own, of course. But I don't know, something that was really unlikely, and that this person was taking your steps, and he managed to cure himself.
Well, I've had one in the last week, which is a triple negative breast cancer. And, you know, that's really hard. Once it gets going, she had 20 mets in her brain, like 20 brain tumors on top of the lung cancer and everything else, and the breast cancer. And it had spread a lot of places. So she was a mess, but she had 2 young kids. She was absolutely determined she was going to try and give it her best shot. And she threw a lot at it. You know, it wasn't just a small cocktail. She did a big cocktail. But interestingly, she managed to get hold of sodium phenylbutyrate as on top of the usual metformin, statin, etc. You know, my normal kind of what I'd say is my normal cocktail. But sodium phenylbutyrate, what it does is it acts as a bit of a prodrug, and it reduces the amount of glutamine in the blood. And I'd never seen anybody actually, because I didn't even know you could get hold of it. Anyway, I've now got somewhere where I know you can get hold of it. But amazing. She managed to just starve. I mean, I thought she'd have to do a big kill phases all the time to get rid of it, but I think I really want to interview her and do podcasts with her, because I want to know exactly what she did. It's helpful for me to know these things, to actually understand what were the triggers. Triple negative, you know, it's so awful. I mean, it gets so many young women who are, you know, in the prime of their life. They've got kids or something, they're young kids, and I see it time and time again. You know, triple negative breast cancer is an absolute beast to get rid of. So the fact that she'd just done it, and I think mostly was starving it, was phenomenal. You know, she did other things. She did, I think she did high dose enzymes as well, coffee enemas. You know, she did the works, awful lot of stuff just to sort of detox her body and get herself into a situation where she was able to just target all those tumors in her body. And, you know, her oncologist is beyond bewildered with the whole thing, doesn't understand what's happened. But, you know, that's a real great success story. I have had other triple negative breast cancer patients recover, but they've never been 20 mets in their brain.
That's very hard.
And everything, you know, really hard. So very impressed with her. I've had lots of people who I sometimes get them when they come and do a consult. I think, right, okay, here we go. This is going to be a tricky one. They go, by the way, I'm in remission, and it's because of these drugs. So now I'm just wondering whether you should think I should do anything else. I'm thinking, oh my God. And I had a doctor came on last week with kidney cancer, and he said, well, I just followed your book and I'm now cancer free. And I'm, oh, great. Well, what are you talking to me for? And I had another doctor the week before who I met actually in Florida. Phenomenal lady, and she did mostly the Kelly program, but she knows about me and she wanted to know whether she should start. And I said, for God's sake, you've done so well, you know, just getting where you are. She added a few supplements, but she did high dose pancreatic enzymes, which helped to sort of, you know, allow the immune system to get into the cancer. And that's something I did as well at some stage. I would be taking high dose enzymes between meals.
Yeah, you took bromelain?
Sorry?
You took bromelain? What did you take?
Yes, bromelain, just pancreatin. I took chymotrypsin, I took trypsin, a whole range of different enzymes.
And always between meals, people, because if we take them with the meal, it just helps digestion. You have to take it in between meals with an empty stomach, right?
Yes. Yeah, and that way it's acting on the cancer, not acting on the food that you're digesting in your system. So, but yes, I constantly come across people, and there are more than one way. You know, this is the great thing about treatments. There are more than one way to actually get rid of it. And I'm not the kind of person to say, just follow the off-label drugs, or just do this, or just do that. I'm open to anybody who can actually get rid of their cancer. Brilliant. And we want to know which are the best ways and how to amalgamate everything into the best system possible going forward, so that people can actually really embrace a way of making everything work for them. I think you have to be committed, and I feel the younger patients are definitely more committed than the older patients. But, you know, it's very hard because it's more aggressive when you're younger as well. The older you get, the less your metabolism is kind of implicated, and you don't have the cell replication. It's not quite as fast as when you're younger, so the cancers tend to be less aggressive. But even so, you know, I have had some many miraculous cures, and you can look at positive progress on my Facebook group, which I'm sure you'll share afterwards. But you know, you can just type in #positive progress and see hundreds of different people doing.
All these cases, all these stories, they just show that the treatment, the regular treatment the oncologists are prescribing is not enough.
Not enough.
People, I mean, the more I read about it, the more I look into it, the more patients I see, I realize that they're just losing themselves. They're missing it.
Yeah.
They're missing the point, and their patients are missing their lives. So this is a shame, and this is a pity. And I think that, when I graduated in medical school, the first thing I said, okay, never do harm. Yeah. So if you don't do harm, I mean, if the risk, right, if the side effects risk is so low, why not? Of course, if you take the dipridamol and if you're taking some other drug that lowers platelets and there's a bleeding risk, of course, every time I prescribe something, I check the interactions, the drug interactions. If I can't prescribe statin, not all the patients can take statins, right? And it's not every statin they can take. It's only some kind of statins like atorvastatin, simvastatin. Rosuvastatin is not indicated anyway. So it's not like, okay, I'll take any statin. No. And even when you take these drugs, the chemotherapeutic drugs or the immunotherapy, you have to check interactions. Sometimes there are interactions with quercetin or metformin, usually not metformin. I'm impressed. Sometimes quercetin, they have interactions. But sometimes the interactions they describe is like, oh, this supplement inhibits the ABC transporter. Great. So we are helping the chemotherapy drug to stay in.
Yes, exactly.
That's what we want. So when I look at this, I say, okay, so this is an interaction I want. Keep this drug.
Yeah.
You know? And sometimes people don't know what they're reading about because they don't study physiology. They don't study the metabolism of cancer and how it goes around our body and how it manages to get into us, right? But I think that nowadays it's unethical not to consider metabolic therapy. As is unethical to offer sugar to cancer patients, especially when we have studies in humans. I mean, we have in colorectal patients studies showing improved survival rates, the lesser glycemic index of the diet. And not only survival rates, like you're looking at real numbers here. It's not like an LDL measure when you're talking about cardiac risk that we know is nothing, right? It's something like dying, it's something like recurrence, and you have studies in humans. And when you tell this to oncologists, the only thing they always say, oh, you don't have human studies, you don't have enough evidence. There's nothing there. I said, have you looked into it? Did you look at least for it? Did you see any papers? You know, I had a triple negative breast cancer patient. I actually took the poster into MHS last 2 years ago. And she had a metastasis in her axilla. It was a lymph node, like 4 centimeters lymph node. So her prognosis wasn't so good anymore, right?
No.
With 4 chemotherapy sessions, the breast tumor and the metastasis disappeared. And there was nothing left. Right. Her oncologist was thrilled. He said, this is not possible. And she was doing intermittent fasting. She was doing ketogenic diet. She was taking supplements. And she's alive. And I mean, after she did the surgery, she completed the chemotherapy sessions, there was nothing there anymore. And she had everything, immunohistochemistry, biopsy. It wasn't very elegantly done. And we could prove that it really worked. So tell me it doesn't work. I mean, we have so many stories to tell, so many patients treated.
Yeah.
Right?
Exactly. So many. Where do we start?
Yeah.
And I've met, and it's so lovely just meeting some of the patients that you know who have got better. So I was at a conference at the Annie Appleseed in Florida a couple of weeks ago, and I had patients coming up bursting into tears and saying, "You saved my life." And that is actually a bit overwhelming, but it's so nice to actually meet people who've actually been there. They've done it. I didn't have to. They've actually done it on their own without me having to coach them or teach them. They've actually managed to work it out, find the doctors, find the treatments, and that's what I'm kind of trying to empower people to do, is to have the courage to go out there and have a go. Even, doctors like you are not, I just want you to clone yourself, because you're just not available to everybody. I would love it if we had more integrative doctors available, because we need ones who are actually willing to go beyond the normal and actually stick their necks out and provide the off-label drugs, the low toxicity drugs that are going to help on top. And this is a major problem for everybody, really. And Dr. Calibu, who was my doctor, who was my source,
he died, right?
Yeah, he died last year.
But the care clinic is working in London, right? The care clinic. They have the COG protocol.
Yes, but then they only do the 4 key drugs. So to me, that's great, but mostly not enough, I don't think, for everybody. So and there are some other, other things like niclosamide, nitazoxanide. Nitazoxanide I just saw come up in research only a couple of weeks ago to show that it helps stop the metastasis to bone for cancers like breast and prostate, myeloma. Those are the ones that really head towards the bone very early. And the nitazoxanide.
There's a phase 3 study with mebendazole for colorectal cancer. A phase 3 study.
Right.
500 milligrams of mebendazole, decreasing tumor size and mortality rates. It's in the clinical trials, and people don't even know what mebendazole is.
Yeah.
And they use a high dose. They use 500 milligrams. And it was well tolerated. It helped. So all these antiparasitic drugs, like ivermectin, also there are some studies, interesting ones. Nitazoxanide, mebendazole.
Yeah. And the ivermectin is very good for triple-negative breast cancer. Works really well with immunotherapies. They're actually doing a trial on that as well. I think it's only a phase 2 trial. But they're looking at a new type of immunotherapy with ivermectin combined. So we'll wait and see what that says. But really, really important stuff. Shown, mice were, about 50% of mice were becoming cancer-free just using the immunotherapy and the ivermectin. Mice study, but we're now doing it in humans. So let's wait and see. Fingers crossed, and let's hope we get similar results. That would be awesome.
Yeah, we have many studies in humans for most of the supplements for other diseases, at least showing safety, right, Jane? I don't see why people should be with fear. Of course, if you use doxycycline, it's an antibiotic, it can cause you dysbiosis. But usually it's 100 milligram daily dose. It's like a low dose, right? We use it for acne, a much higher dose for much longer time. So most of the off-label drugs, they're safe. Of course, they can be drug interactions. We have to look into them. But most of the supplements are like really safe, right? And people shouldn't be so worried. Always, when I prescribe a supplement, I always look for human studies when I'm looking at the dose. And always we're looking at clinical trials, looking for a dose. If someone has done it before, at least to see toleration, in this high dose, it's not well tolerated, like albendazole is not a good choice. But mebendazole is used in children in Brazil, like for ages we used it. Like double the dose they're using it now. And this 500 milligrams dose is very safe. And there are studies like phase 3.
And Gregory Riggins, who's kind of the big instigator of mebendazole at John Hopkins, he was using 800 milligrams for kids with GBM, with brain cancer. So, a much higher dose. I have a few issues, though, with mebendazole in that it does upregulate a nuclear factor. So one of the inflammatory pathways, the nuclear factor kappa beta, part of that pathway.
Yeah, but
and I
you
think
never
it's important.
you never use mebendazole alone, right? I mean, at least
No,
we
exactly.
wouldn't, not in GBM.
Exactly. So you need to have something to suppress that
Like
at the same time as
Boswellia, like
you.
curcumin, like
Yeah,
lots, like CBD
yeah,
oil,
yeah.
like lots of stuff.
Sulforaphane. And all of those things are very useful. And berberine as well, actually, really good for that. Yeah.
Yeah, I mean, actually, if you take into account all the supplements you suggest and all the pathways you suggest, we should tackle and look into them. You even say this in your book, right? I mean, if you only block this pathway, the cancer will go around it, which I think is genius. Because when I began studying, Jane, I must tell you, I was reading about it in the papers and the press pulse therapy. So you guys saw her saying this kill phase, what's star phase, kill phase, press pulse therapy. And most of people are not familiarized with that. Jane, do you want to explain what it is about? Tell them.
Well, I've kind of taken Siegfried's press pulse approach. His was press was doing a bit more diet, and then pulse he'd be doing.
No, he called pulse ozone, hyperbaric oxygen therapy.
Yeah. And so a similar thing, but my kill phase is also much more of a pro-oxygenation. The star phase can be lots of different antioxidants and things like that, and that's fine. Then the kill phase is more pro-oxidant, so you really want to go for a pulse of oxygenation to try and wipe out some of those cancer cells, because they are susceptible to oxygenating therapies, like high-dose intravenous vitamin C, for example.
I use it.
Yeah, I know you do, because you use it in your ferroptosis treatments.
Yes. So,
which I want to ask you about. Can I?
Yeah, sure.
So I know that some cancers are particularly hard to treat. I have been referring a few people with sarcomas directly to you, because actually starving sarcomas I find really hard. They are one of the most difficult cancers I have found to actually get good results with. So I think ferroptosis is kind of the key treatment that they need. Probably people haven't got a clue what I'm talking about with ferroptosis. If you've only just met me, never heard me talk before, ferroptosis is using iron to trigger cell death by using oxygenating therapies. It's a bit more complicated than that, and you don't just take iron. In fact, for most cancers, you don't want to take iron.
Yeah, you should avoid taking iron. You just take iron, and it's absolutely necessary.
Yeah. So depends on your ferritin levels, depends on all sorts of factors. But essentially, it's using iron, which cancer loves, and it's using its need for iron to actually kill it.
Yeah, cancer cells, they love iron so much that they kidnap it and sequester it inside the ferritin molecules inside the cells. So cancer cells have more ferritin molecules inside them. And it's very common to have high ferritin levels with low iron, free iron, and low saturation, the transfer in saturation levels. And the patient feels anemic, he feels tired, he's like very tired. And you look at the other signs of inflammation, they're not so high, like the ESR. And then you're certain that this patient is like, he has iron, he just doesn't have access to it. Because iron is so important and it's so dangerous for the cancer cell that it has all regulated. Because if the iron escapes and if you give it stimulus for oxidation, this iron will be oxidized and will oxidize the lipid membranes in the cell and will trigger apoptosis and the cell will die. So it's something so dangerous that apoptosis is very regulated in cancer cells, right, Jen? And if you know how to use it, intelligently, like inhibiting BCL2 and all these apoptosis inhibiting factors. And if you stimulate the other ones, like BAX and all the pro-apoptosis, like I love using dichloroacetate. Like I use it a lot. And the ferroptosis protocol, actually, who taught me? Ahmed, Dr. Ahmed Al-Saka taught me about it. He's my friend. He's your friend. He's brilliant.
Yes.
He's an Egyptian doctor.
Yes.
He's a specialist. And I met him. He had this poster about ferroptosis protocol. So I sat down by his side. I said, you must tell me everything about it. I won't leave your side until you tell me everything about it. So we talked for 2 hours. And then I looked into it in the literature. And I saw so many papers from 2015 onwards, like lots of papers and growing literature about it. And I said, no oncologist talks about this. And they even use some drugs that could help ferroptosis protocol, like for liver cancer and stuff like that. And I had a sarcoma patient. I still have her, thank God. She had a sarcoma in her knee. She was bedridden. I hope you meet her someday. I hope you interview her someday. She was bedridden, and the doctor said she had 6 months to live.
So she was how old?
She was 30-something. 31,
13.
32, no, 30.
Oh, 31.
Yeah.
Okay.
And they took so much time to make the diagnosis because the biopsies were not conclusive. She did like 3 biopsies. Right. By the time they finished doing the third one, she did a PET scan, and it was lighting up in her back, and they didn't biopsy it. They just concluded it was metastasis, and they said, you're going to die anyway. There's nothing we're going to do about you. You could amputate your leg if you want. It's not going to save your life because you have a metastasis, but they didn't biopsy it. So, and then she said, okay, if I'm going to die anyway, I'd rather not amputate my leg. I want to see other options. Then she lived in another city away from me. She found me on the internet. Actually, her boyfriend, which is so nice to her, he found me. And she did an online. She saw me online. We talked. I said, okay, I can't tell you not to amputate because if it's the only chance you have to save your life, do it. Okay, so I'm not going to tell you not to do it. If your oncologist is saying do it, I'm not going to be the one telling you not to do it. Trust only in integrative medicine. I'm here to do a complementary medicine to help your treatment work. And then she said, but there's no treatment. They never prescribed any treatment. They didn't offer me any option. They told me I should go home. She was using a patch of morphine, and she couldn't sleep, and she couldn't bend her leg, and she couldn't dress alone. So then I told her, okay, so I'm going to give my best shot. You're away from me. You should come and do injectables and do ozone and lots of things I can do for you. But let's see what we can do. If you respond, then you come. And then she started a ketogenic diet, measuring GKI, like always under 3, and measuring ketone levels and blood glucose levels. She was like perfect, And then she started taking my supplements. Okay, so after 15 days of taking my supplements, she began sleeping again. After 1 month doing the protocol, and this is only supplements and diet, okay? No pulse therapies.
Wow.
She was off the morphine patch, and she could stand up.
Yeah, brilliant.
Then she started going to the gym. She could go to the gym. And she was walking with a cane. Okay, so she made a decision. She came to Belo Horizonte. She was there. She moved to Belo Horizonte. At the beginning, she was going to stay for 2 or 3 months to do an IV protocol. And then I was seeing her every 2 months, every 3 months. In the beginning, we did high doses vitamin C with alpha-lipoic acid. And then she had high ferritin levels. We did ferroptosis protocol. And we did and actually, I made a juice for the ferroptosis protocol with watercress. Watercress? Oh, no. How do you call it? It's watercress, right? Which has PTC, yes. Cucumber. Yeah, so I took all the ingredients I couldn't buy, and I made a juice for the ferroptosis protocol. Yeah. So there's this juice. So there's the juice of the ferroptosis protocol, which is with broccoli sprouts. I taught them how to germinate broccoli sprouts. In the 4th day, you freeze them to get most sulforaphane out of it, and then you can do this juice in the morning. You take it out of the freezer and do. So I taught my patients. I have a video on YouTube. Yep. So I have these 2 juices, one for the ferroptosis protocol, one outside the ferroptosis protocol, because sulforaphane inhibits ferroptosis. So,
well, actually, I'm reversing my thoughts on that, because the sulforaphane will actually block the XCT antiporter, which is that pathway that cancer uses to get cysteine in. And even though sulforaphane boosts the detox pathway,
Yeah.
the NRF2, you can inhibit that with some things like brucitol, trigonelline. There are some things that you can take to inhibit the NRF2, but the sulforaphane may be fine.
Yeah, I avoid it as a supplement. Like I keep the EGCG though in high doses, and I avoid sulforaphane because when I do the post therapy, I really want to give high dose vitamin C with this protocol. So I usually avoid it. But then we did this, and she was like, it was 1 year already, and she was alive. Like she should be dead in 6 months, and the tumor didn't grow. Actually, it diminished the size visually. And she was walking again without a cane, and she was doing trekking. And she never used CBD nor morphine again. And then we did, then Ahmed came for the first time, and her lab tests were not good. So I think, okay, maybe there's something going on with this tumor. Maybe it's becoming resistant to this therapy. And Ahmed did sonodynamic therapy on her. And that's when we began doing sonodynamic therapy in the clinic. So he came, he taught my team, and we began doing it. And she had a great response. The tumor diminished in size, but it was really vascularized. So we got into a limit that we didn't get more improvements. And she was doing great. Like she was doing tracking, she was feeling fine. And the sole metastasis, when we did the thermography, it never lit up. So I was always, I found an oncologist, said, listen, I mean, she doesn't have money to treat this forever and to pay for these supplements forever. It's very expensive for her. She's in another city. And this thermography never captured this tumor. Are you sure this is a metastasis? Because for me, it's really strange. She's not dead.
But the sarcomas are very driven by amino acids rather than glucose. So they don't always show up on PET scans. And I have several sarcoma patients who come to me and said, well, it never came up on a scan. So I think the amino acid side is critical, really.
It could be. This was like 2 years, almost 1.5 years or 2 years, and she was alive. Then I don't know, she saw an oncologist, and they said, no, it's not possible. You should be dead by now. This is not a sarcoma. And then she said, okay, I've been through this. It is a sarcoma. I'm doing this metabolic treatment with Janaína. She said, no, this doesn't exist. It doesn't make sense. It's not a sarcoma. We have to biopsy it again. So all again. So she went to this, she did all the biopsies again, and it confirmed it was a high-grade sarcoma. And they said, okay, you must operate immediately because you're not dead because you're very lucky. She said, yes, I've been lucky for the last 2 years. I mean, and I'm not dead because I'm doing this treatment, No, okay. We don't believe in this treatment, should be operated. And then they convinced her to do an operation on her knee. But it was a very hard one because the risk of metastasis was high and the risk of her losing the leg was high. But she decided to do it, I wanted to do a more metabolic treatment before that. But then he said she should be dead by now, so she should do it, She decided to do it. So she did it. And after she did it, she recovered very quickly. She didn't lose her leg. But a metastasis appeared after the surgery. Yes. In the leg. In the same leg. Yeah. Which happens all the time because in the surgery procedure, and we use celecoxib, we use propranolol, which I think is great before the surgery and 2 weeks after the surgery. So I prescribe it to her. I use it always. But still, she had a metastasis, and now she's treating. Now they began chemotherapy for her, but she is like the best patient they've ever seen because she recovers too quickly from everything they do. Because she's doing again the ketogenic diet and she's taking the supplements. So she's unlike any patient they've ever had. They keep telling her this, But she's a warrior. I mean.
Yeah, brilliant. So sarcoma is a tricky one. I've always found it very tricky for patients to do well with that. But propranolol is a really useful supplement for them for sure. And the ferroptosis protocol, again, big one. So well done, fantastic result.
Yeah, I
really.
mean, it could be more fantastic if she was cured. So now
I
let's
know,
see.
I know. There's still time to do that.
Yeah.
So, I have patients who actually start and 5 years later, it takes them 5 years or something, and they're finally there. But, it can take time. It can take time. I have a lot of patients who are like that, and they have a little blip here, and then they change things around, and we have a look at jiggling things about, and then off they go again, and then they get it down, and then another little blip, and then we get it back down again. And, I have a lot of patients who are no evidence of disease. They've always had a little bit of something, and it gradually goes down. And that's the great thing. That's the great thing. And I love that.
I see some patients in these studies about protocols, like the alpha-lipoic, naltrexone, and hydroxycitrate protocols. Usually they do only this, and like they do low carb. They just don't write it down, but it's low carb.
Yeah.
And usually, if you see the scans, it's like, okay, in the first 6 months, nothing changed. But this is already a win, and the patient doesn't realize that. If the tumor doesn't grow, it's a win. Yeah. But they want to be cured. Win. They want to be cured in a day. They don't understand that. And then in the subsequent scans, like 1 year afterwards, then the tumor disappears. Then they stop. Then the tumor comes back. Then they're again, because I think it takes time, because you're not doing like a chemotherapy that kills everyone and you. You're doing a metabolic control, and it's fine if you find a way to control cancer like you control hypertension. It's okay too. It's not bad.
It's okay to have that. It's okay to have tumor.
It doesn't mean a metabolic protocol is failing. It just means that you have a different way of controlling a disease that might otherwise kill you. Right?
Yep. Exactly.
And they feel fine when they're doing it. Okay, the ferroptosis protocol, it's difficult, right? Because sulfasalazine can be a problem. Yeah, it has GI issues. Some patients don't tolerate it. I'm trying with, I have these ovules and suppositories to do it rectally sometimes when patients can't tolerate it orally.
Okay. Have you tried piperlongumine, long pepper?
I don't have it here.
Okay.
But I can get hold to it, I think.
Mm.
Why?
And even well, that works very similar to sulfasalazine, but it's natural. And I think together they would probably work better. Olaparib, which is a PARP inhibitor, actually works really well, a bit like sulfasalazine as well.
Yeah, some things we don't have in Brazil, like I adapt. I have like a list of supplements, and I say, okay, what can I get hold to?
Yeah.
For example, nowadays, I'm dying to get acridinorid and acriflavin in Brazil, and we don't have it. I'm dying to get acriflavin for bone metastasis.
Yeah.
I think it's one of the ways, I've been studying a lot about acidity and about the vacuolar ATP pumps, and about acarbose and about how to decrease the alkalinity intracellular and decrease the acidity outside, to inhibit metastasis, to inhibit bone metastasis, and to kill the tumor with little number of supplements, like acetazolamide, like acarbose, like acriflavine, and lactate inhibitors, and diet, And I think this is something really big, because it's like it's very specific. Amiloride, it's very specific. I told you about amiloride when we met. It's very specific. And now I found so many papers about amiloride preventing cachexia, which is great, because it's...
Yes, I have seen that too. Yep, and fantastic. And I had a patient come and see me in Florida, and she was doing phenomenally well. She'd had all manner of problems, and she was on a whole load of, she was on amiloride because she had edema in her legs. And I said, you know what, just keep on that, because it's really helping you. Don't come off that. Keep taking that, because that's really helping your cancer. And she didn't have any bit of cachexia. She was looking healthy, and she wasn't healthy, but because she was riddled with all sorts of stuff, and she was walking on a stick, but essentially she looked healthy, and she was bright, she was breezy, she was an absolute gorgeous lady, full of bubble and spirit and joie de vivre. And I thought, fantastic, you're doing well. Keep on that ride.
Patients that actually they comply with the treatment and the diet, they look better, they feel better, and the chemotherapy strikes them less than people who are not doing it. Because they, especially if they manage to fast. Like I have some patients, this triple negative patient, she was on chemotherapy, I know, once every 21 days, something like that. And she would be fasting 24 hours before the chemotherapy and 3 days after, you know? And in between, she wouldn't fast because she wasn't fed or anything. So I said, okay, you're going to fast around chemotherapy because this is going to boost the effect and protect you. And she did that. And I'm pretty sure it helped. But not all the patients are like, you know, they're like, okay, I'm going to fast. I believe in this, you know. They don't realize how powerful fasting is for treating cancer, especially during chemo and radiotherapy, because it protects the healthy cells. But not many people talk about it. And you have the fast mimicking diet. You know, Walter Longo did it on animals. It works. So some patients, we do the fast mimicking diet. 5 days a month, especially during chemo. It's great in GBM because temozolomide is 5 days a month, so we can do it. I did it in some patients. But I'm very sad because some GBM patients, they come to me when there's nothing left to do. Like there's, they say, okay, you have 15 days to live. Then they find me, you know, like in desperation, they find me. They have 15 days to live. Go home to die. You have nothing else to do. Then they find me. So it was very sad because I usually tell them, okay, it's very little we can do in such a little time. I can help you have life quality, and we can pray sometimes. If you have an IDH mutation, ketogenic diet can be very helpful for you. But if you don't, it's difficult to expect that a metabolic treatment will help so fast. So there's something people should know as soon as you have a cancer diagnosis. Change your lifestyle. Absolutely. Don't wait.
I met this guy who's a friend of a friend. So he'd been told immediately, go and see Jane, because my friend Marcus just said, see her immediately. And I met him Sunday afternoon in the cafe. And he still had stitches from his operation, which were done sort of a week ago. He was still fresh, new, just been diagnosed with GBM. It's like, yes, I've got him early. Shame I didn't get him before the operation, but I have him early. You know, fantastic.
That's fantastic.
And you know, I hope he does well. I'm hoping he does really well. But you know, the earlier you can get there, the better you can get the results. And I just wish more people would know more about this and instigate some of these changes and come and see people like you earlier.
Yeah, I think people are not listening sometimes, Jane. Because you're a physiotherapist, right? But I mean, but I mean, you came from the health environment, you know? You studied anatomy, you studied biochemistry, you know? You're not like anyone who doesn't have a clue about human body, you know? Who's telling people something out of your head. You're someone who had cancer, who was studying biochemistry, who did your own research, who came up with truths that are being confirmed study after study, you know? You should be respected. I mean, I look up to you. You know, I'm a doctor, I'm a metabolism specialist, I'm an endocrinologist, right? I look up to you. You know why? Because you simply came with so much alone. And I say alone because I read your story. I see how people only look up to doctors who don't have a systemic view like you do. I see like very respected personas there saying, okay, so all mitochondria are harmed in cancer. That's not true. They're simply not true. Actually, cancer has many types of populations in the same tumor, right? And we have even parts of the tumor who are doing glycolysis, and then out of the blue, they begin doing oxidative phosphorylation because it's not their mitochondria don't work. They have metabolic flexibility. And you said it in your book. If you block this pathway, it will go to this pathway. And it does. And this is not speculation. It's published.
Yeah. And reverse Wahlberg is known as the reverse Wahlberg effect. And it's not properly acknowledged by many people yet.
No.
That actually a lot of the surrounding area of the tumor, like the immune cells, the stroma, the fibroblasts, they can be the ones that are actually doing more of the glycolysis, feeding lactate, and the tumor cells themselves can be feeding off that lactate, turning it back into and using the normal Krebs cycle to feed themselves. So it's a mix.
And actually, lactate is the hormone of cancer. It's the language.
Yeah.
Lactate is the most important signaling molecule in cancer. And people are not looking into it. They think it's just a bystander, a marker of prognosis. And they don't see which diet reduces lactate the most. You know? Certainly it's not giving sugar to the patients and ice cream. Certainly it's not giving pasta. You know? So I think it's like it's cognitive dissonance, it's called, when it's in your face and you're not taking action, right? And even in our field.
And you don't ignore the science coming at you because you are so sure that you're right.
Yeah.
And it's extraordinary.
And you know what? Now, I always look in cancer like as a systemic disease, and like how sleep is so important. And melatonin, I do IV melatonin. I do high doses of IV melatonin. I have Bicalane injectable here. I have curcumin injectable here. I have dichloroacetate injectable. I have vitamin C. I have chrysine. So I can make all sorts of protocols for my patients depending on the cancer, you know, which is great. I have Viscum album here. I have fermented Viscum.
You need to quadruple or even bigger than that. Just grow your practice 10 times and you should be getting, everybody should be, you know, I think you should get all the sarcoma patients to start.
You know, but the thing is, in Brazil, it's cheaper for foreigners. For example, if someone comes from England to be treated here, for them it's going to be cheap. For Brazilians, it's not so cheap because the supplements are expensive. It's easier to manipulate in a compound pharmacy. You know, for example, I have this mushroom chocolate. I make a chocolate. It's a diet chocolate with mushrooms. I put maitake, turkey tail, and reishi, Ganoderma lucidum. So I make this mushroom for immunity boost, you know. It makes people feel better. It makes you increase your Th1 response. It makes you inhibit your M2 macrophage. So I like working with that. And also the Viscum album and Valasta. Have you read about Valasta? This liquid,
astaxanthin.
The astaxanthin. It works like a PDL1 thing. So I'm working with that too, with patients who can bring it from abroad. So some things we have here. Thank God I have this compound pharmacy. I can make liposomal drugs now. So we have methylene blue. It's liposomal methylene blue. We have hydroxycitrate, liposomal. We have EGCG, liposomal. Ahmed came and taught people how to do it. So I have good treatments for drugs. I can have everything, almost everything in the protocol. And I have injectables in the clinic, and I have a zone. I still don't have hyperthermia. I want to have hyperthermia. And I need an oncologist to do insulin. I have to do pre-chemotherapy insulin. I know it in my heart, so I'm looking for an oncologist who wants to work with me here. So if you're listening to this and you want to work with me, come. I need an oncologist here. It can,
And I want a doctor to work in England that I can work with and train up to do all these things as well. It would be, we're desperately short now in the UK.
Yeah, I mean, I don't want to study oncology because I don't want to prescribe chemotherapy. I want to be the metabolic doctor because I am a metabolic doctor. I am an endocrinologist. And there's so much to study, right, Jane? I mean, these supplements, these phytotherapics, this off-label drugs, the more we read, the more we realize we know nothing and we need to study more. So it's not like I want to be the oncologist. I don't. I'm pretty sure oncology has its place, right? I respect it. I'm pretty sure. The thing is, I can improve them. I can improve what they're doing. I can help. It's not like a competition. It's not charlatanism like they say it is. I'm backed up by science, sound science. At least if you talk about fasting and ketogenic diet, the animal studies, we have meta-analysis of randomized controlled trials in animals showing good evidence, and hyperbaric oxygen therapy with ketone esters. So now I have this guy who brings kinetics to me in Brazil. So I have ketone esters if I need, at least in radiotherapy. During radiotherapy, I like giving people ketone esters. So they're on ketogenic diet. They take ketone esters. They're taking doxycycline. They're taking Boswellia. You know? Everything I know, it's going to boost radiotherapy because it helps. So I think we have to talk more about this. We have to sum it up, you know, we have to team up.
Yep. Absolutely, absolutely. And, low dose metronomic chemo is also something that people are not using enough. Because the more you use of all of these drugs or supplements, the less of each one you need in order to get a synergistic effect. A low dose metronomic chemo works in a completely different way.
Yeah, it doesn't kill your patient.
Doesn't no. And what it does is it helps reduce the VEGF, that the new blood vessel vascular endothelial growth factor. So it's reducing that, and it's also boosting. So it sort of clears off some of the bad immune cells that are suppressing the ability of the good cells to get in there. So you actually get a boost of the T cells. That are, the T infiltrating lymphocytes, the ones that are actually going to kill the cancer.
The ones we want.
So things like that are so important to know. And I think stage 3 and 4 cancer, giving high dose chemo, how often is that going to work? As I had high dose chemo second time round, but I had, was it 2 or 3? I managed to get the dose reduced. All right. I did the full performance of this is going to kill me. I feel dreadful. I'm not having any more unless you reduce it. I refuse to have it. I feel so ill. I can't have it. And she dropped it down. And here I am.
Yeah.
So, but if she can give me the high dose, I don't think I would be.
But at least in these patients who can't tolerate chemotherapy in high doses, so many patients can't tolerate it and they just stop it. Why not simply stop it, wait for the patient to recover, and then start over again, low dose, together with the insulin pre-chemo, together with hyperthermia. You can do it inside the clinic, the oncology clinic. We're not trying to steal patients from you. We actually go there and teach you how to do it. We go through with you. I can be there when you do the insulin. The patient's not going to die. We do it all the time. We do the ITT test, the insulin tolerance test. It's something like, we do it all the time. We give insulin, wait for the person to have hypoglycemia, give glucose again. It's the same thing. Everyone does it all the time in endocrinology, but you do it before chemo, right? And the patient won't even feel sick because he's in ketosis, so the hypoglycemia won't even make him feel anything bad, right? It's not the thing. When you have a hand of it, and then supplements and the diet and the fasting, and then the patient suddenly responds, and it's not there like feeling bad, doesn't have all the side effects, and it's another kind of post-therapy. It's okay. Yeah. So it's just that if they start with these patients, like, okay, let's try. There's nothing else we can do with you, right? Nothing else. Sorry. So okay, let's try this. Low dose metronomic chemotherapy with insulin, hyperthermia afterwards, and hyperbaric oxygen therapy, supplements, right? Let's try something different. If there's nothing to offer anymore, why not trying something different? It's not magic. It's published. Slocum is doing it, right? It's published.
Yep.
Many patients treated, right? Insulin pre-chemotherapy comes from Mexico. Like there's this guy decades ago who wrote about it, And no one even remembers, like, hey guys, this is being said like decades ago, like ketogenic diets. You're so afraid of eating fats. You can't do a Mediterranean diet, eat avocado and nuts, You're so afraid of a diet which is done 100 years ago and saved thousands of lives of children with epilepsy. We're not proposing anything so new, are we, Jane?
Nope, it's not new. It's actually very old, all of it, really.
Yeah, berberine and is used for hundreds of years. Yeah, I mean, Ayurvedic medicine and Chinese traditional medicine is done for 1,000 years, or more.
And some of those, and we're only really starting to appreciate the power of some of those Chinese medicines. I mean, amazing.
Like
some
Dunshan.
of them. Love it.
Dunshan for bone metastasis.
Yeah, love it. And on its own, it apparently helps to stimulate ferroptosis and breast cancer.
Dunshan is great.
So, yeah, it's very good, very good. So many things.
So we could be here for ages talking, and I could talk to you for a week non-stop, and I wouldn't even feel sleepy. But I know it's late there. But I want you to tell people about your new book, which talks about ferroptosis. I read it already. And also about your online course. And I think all doctors who want to start learning about this should take Jane's course. I do have a course in Brazil, but it's not online, and it's not always, so it's not available. And usually when we do it, not many doctors come because it's in person. And when we tell them it's very cheap, you know what they say, Jane? They say like this, oh, but I don't treat cancer patients. I don't like cancer patients. So I tell these doctors, if they watch me and they watch this podcast, you don't have a choice, my friend. In 10 years' time, you can count at least 2 out of 10 of your patients will be with cancer. You know why? Because this is the most prevalent disease nowadays, and it's the high, in the ranking of killing people, it's cardiovascular disease and cancer everywhere. So, and it's not going to get any better. And the health insurance won't be able to pay for the new drugs. You'll be in a dead end. The oncologists are walking to a dead end, and they don't see it.
They are. You are so right about it.
They are. So
and you're right also that the doctors, the integrative doctors, are probably too scared to treat cancer, a lot of them. I can see that. I just wish they had a little bit more confidence. And that's where you need to be teaching more. I'm trying my best. So, I have my online course, which people read my book. Some people get totally overwhelmed, and that's perfectly understandable to get overwhelmed with it to start with. Most people read it once, and then they leave it for a week, and then they go back to it and read it again. And sometimes it takes about 3 reads, and then they really start to get it. And then they do my online course. Once they do my online course, I think the light bulbs start switching on.
Yeah.
And that's the important bit, is to really get people to understand it's all about combinations to block those key metabolic pathways. So you're not allowing it to reroute its way around. Course is done very well, and that's on Teachable. Teachable, if you look up teachable.com and then how to solve cancer, you'll find it.
No, I will put the link here just under the video, you won't have to look for it. Don't worry, it will make it easy for you.
Perfect. Perfect. And people can put in a discount for you. So Koenen, I probably pronounced that incorrectly. 10.
It's perfect.
We'll put that in the link as well. And my book is on Amazon, and it's on my...
We'll translate it into Portuguese eventually. I hope I can be part of it.
I really hope so. I need to find a Portuguese publisher, ideally.
I'll find one for you. I'll find one for you. I'll do it.
That would be awesome.
I'll find one for you.
If you can find somebody for us to approach,
I will.
That would be perfect. Perfect.
I will.
Thank you.
We need to do this because this information has to be wide open. It can't be, segregated anymore. And you should sell your book in Metabolic Health Summit. It's a very important book. Everyone respects you. We'll make a motion. I couldn't buy it there. I looked for it and it wasn't available.
Yeah.
I would have read it on site. But I'm glad. Yeah. I'm glad Nasha told me about you. I'm glad I bought the book. I'm glad I read it. And I can tell you that it began my work like a real work, because before you, I was only looking at all the mitochondria are failing, all mitochondria have problems, And if you do ketogenic diet, it's enough, and only some other stuff. And I see it didn't work so well. So when I read your book, I said, okay, because I'm an endocrinologist, everything makes sense. I said, this is something I grabbed my attention. I have to work on this. So I began my work about this, and then I built my I have this Excel dynamic table, and I'm improving it now. I want to publish it, and I put some other stuff too. I have like this MindMeister. How do I see cancer now? It's very confusing, and so I put it into the paper. I said, okay, now I see it. So I hope it helps people too, and I hope we can work together. I hope we can design stuff together and have a research group together, because we need this.
Yeah.
We need
Yeah,
this.
we do. We do.
And if we stay alone, Jane, the
I know.
system will crash us, because it's easy for
Yep.
them. And that's, they don't want to change. It's a lot of
Yep.
money, Like one treatment, one of our treatment, like if you buy all the supplements, I don't know, you spend like $10,000 if you do everything. I don't know how it. In Brazil, if you do everything, that like all the supplements, they cost for 4 months. The supplements will cost, I don't know, 7,000 reais, which is like $1,500, let's say.
Wow.
One vial of treatment in Brazil costs $50,000, 50,000 reais, which is $10,000. One vial of one of the drugs they do. So it's not an expensive treatment, if you look at it this way. But the health insurance system is not prepared or doesn't want to treat yet. Now,
Right.
But if they see potential, because they're spending thousands of dollars in failed treatments who doesn't work, and actually they extend lifespan 1 month, 45 days.
I know.
And miserably, right? Because the quality of life is miserable. And they're like promising patients the world, but never comes. Right? It's like immunotherapy works for 30% of the patients. It works for a while. If you have the beginning, okay, great. If you don't have a targeted mutation, So for stage 3 and stage 4 patients, what can we offer to these people? Are we offering everything we can? Are we doing our best? In evidence-based medicine, are we doing our best? I can assure you we are not.
And I can assure you we're not as well. Yeah. It's just so obvious to me, that we're just not doing enough for these people. And I just wish more people would understand and acknowledge you need to do these extra things. And it would be so much better if we had more doctors. I want the NHS to try and fund some of this. Somehow we've got to have an integrative clinic that actually provides all of this for cancer patients. We need more of them. We need them up and down the country, providing the treatment for cancer patients that are cheaper and easier than the horrendously expensive treatments that they're currently on.
Yeah, and if you compare the price, it's much cheaper. It's like ridiculously cheaper. But if you make the patient pay for it, all of it, for the patient, it's expensive. So unfortunately, nowadays, it's not easy. It's expensive. If you come from abroad, it's not so expensive. If you compare in the other places in the world, well, integrative therapies for cancer are provided. Like in my clinic, I have the ozone, I have the injectables. We have hyperbaric oxygen therapy, not in the clinic, but we have it in my city. If the patient can pay, we can do it. And we have a compound pharmacy. It's not mine, unfortunately, because if it were mine, it would be cheaper. But it's not mine. But they're very keen on studying and researching. And if I tell them I need this drug, they provide it. I need resveratrol in cream base, because in cream base is 65% bioavailable. And if you take resveratrol by mouth, is 1% bioavailable. So if you micronize it in Pentravan, you increase the bioavailability to 65%. So I can use 150 milligrams 3 times a day in the skin. So you imagine how much resveratrol I have. And I have injectable resveratrol too. So I do it intramuscular in the clinic, inside. So it's different when you have these options. I have bicalene, I have curcumin, It's good, and you can change the protocols. And it works, you know. So this is, unfortunately, I still don't have the oncologist to offer. I have an oncologist who is open.
Do you have? Yeah, good.
But she doesn't do
Okay, what about photodynamic therapy? You mentioned that
I have sonodynamic and photodynamic therapy in the clinic, yes. Okay, we still don't have it with fiber optics, which we will. And we have a doctor who is going to train. You insert the fiber optics inside and you do sonodynamic therapy inside. And I want to get hold into better sonosensitizers. And we have now some of them, but I want to have better ones, especially for bone metastasis patients. Sometimes I wake up at 3 o'clock in the morning, I have these ideas, and then I start Googling it, and I can't sleep. And then I design a protocol, so I start studying. I don't know how to explain that, but it happens in a while, and it happens sometimes. So I did this, and now I'm obsessed with some sonosensitizers and some machines. So we are buying new stuff and improving the clinic. And I think in a year time, we'll have like a good surprise in Belo Horizonte. Brazil is nice. I mean, I live in the mountains. It's a very nice place. And I think some people from abroad will be happy to come and be treated here. I hope so.
Well, I refer quite a few people to you. So they should go. They should go.
Yeah, let's hope so. Yeah, we will change the information in the site, so it's a direct line to the clinic, because sometimes I don't get emails. They go to spam. I see
done that already.
Oh, great.
You gave me a change of information for my website, so I think I've updated that.
Oh, I hope so. I'll check. That's great.
Yeah.
Okay.
Check it out.
We have to do this more often.
Yes.
So
yes, definitely. Love this. Thank you. So much information for people to take on board. I think we rattled through a lot. Let's just say a lot. So people we are going to have to cut it into bite-sized chunks probably for people just to digest maybe a bit. But fantastic.
You know what we could do like short lives about, you know what, something that I love, I find it beautiful if it wasn't tragic, metastasis, like epithelial mesenchymal transition and supplements that tackle into this. I think only this subject deserves a whole podcast.
Yeah, absolutely.
We could do it and explain to people why debridement is so interesting. How does a metastasis happen? And we can be very simple in explaining it. I have like a whole idea. I can say we should do it. Let's arrange it.
Okay. Can I interview you?
Yeah.
All right.
That's great. Oh, I'll be glad. Okay.
Okay. Thank you so much.
Thank you, Jane McLelland. I can't thank you enough. I'm so glad I had this opportunity to talk to you and to learn from you and share a bit of what now it's my passion. I can say I treat endometriosis the way I treat cancer. And I think you should look into endometriosis too, because these patients suffer a great deal. And we can talk about it. You can interview me about endometriosis, and you'll understand why. And my clinical experience is already good in it. So let's talk about this. I think you would help a lot of people, not changing anything you say. But it's a whole set of people, of women suffering, having huge surgeries, having metastases, infiltrations in the bowels, having pain, and nothing works. Nothing works. So no one is looking at them. So I think you should look at them like I am looking at them. So we can talk about this if you want.
Great. Super, because really I don't know any specific treatments for endometriosis.
We'll talk. You do know.
Oh,
actually, you know. Actually, you know. It's just you're not just looking into it. Like the oncologists don't look into it. You know, no one looks into it. But we'll look into it, and we'll talk about it, and you'll see how much you know. You know a lot. And then you'll see a whole new market of people dying of pain with no help. You'll see. Okay. So now I mean all of you curious, right? So thank you so much.
Fantastic that you've looked into it. Okay, super to talk to you. Thank you so much.
Thank you so much. Bye-bye. Okay.
Bye.